Hello, I'm Joan Randell from the Nicholson Foundation. I'd like to welcome you back after, I hope, a nice lunch to our afternoon session where I think you'll see a good, lively discussion like we had in the morning. I'm pleased to introduce our next keynote speaker, Dr. Farzad Mostashari. As a physician, Dr. Mostashari has spent a good deal of his professional life focusing on payment reform, care delivery transformation, and helping the United States build a health information technology infrastructure. He served as the former National Coordinator for Health Information Technology, where, among other initiatives, he led the implementation of the HITECH Act, the Beacon Communities Program, and the Meaningful Use Incentive Program. He is currently a visiting fellow at Brookings Engelberg Center for Health Reform. Please help me in welcoming Dr. Mostashari as our next keynote speaker.
Thank you. Thank you, Joan, and thank you to the Woodrow Wilson School for inviting me, and thank you all for being here. I must admit, this is not the first talk I've been asked to give on the topic of big data. And every time I have a little bit of an imposter syndrome. How many of you, like me, aren't sure you really know what people mean when they say big data? All right, who here's thought that they really knew what big data is? Because I want to talk to you. All right, afterwards, can you please coach me? Thank you. I'm going to need that. I'm going to go back, therefore, to what I think big data is and what most closely approximates it in my life. And this actually started 15 years ago when I was an epidemic intelligence service officer for the Centers for Disease Control and Prevention. I was stationed in New York, and my job was to detect outbreaks and investigate outbreaks. And this is before the big outbreak of West Nile hit and kind of took over my life for a little while, and we had some listeria outbreaks, and it was before anthrax attacks. But I was visiting our colleagues in the fire department, and I noticed that on their beepers, yes, they had beepers. Nowadays, only doctors have beepers. They had beepers, and one of their beepers buzzed at noon. The guy looked at it and said, "Oh, volume's up a bit today," and put it back. I said, "What was that? What'd you just do?" And he said, "Well, you know, the fire department dispatches ambulances. And if the volume, we get a little text that says like what the midday volume was, because, you know, if we don't want to know if we were getting slammed." And I was like, "Really? So when you dispatch the thing, you can track the volume. And some days are worse than other days. That's interesting. Do you know anything else about the dispatch?" And he said, "Well, we put it into some one of 54 categories." And I was like, "Have you ever looked at it by category?" And he said, "No, but you know, you're welcome to kind of look at it." So you look at it, and there's some categories, right, that kind of go together. Like, you know, they had basically a respiratory category. It's really rough. Like, it's like what someone on the phone told the EMS person, like, dispatch an ambulance because blank. And it's almost, you know, a lot of the time it's not what they said it was, right? It's bad data. It's dirty data. It's terrible. It's completely unreliable, except when you look at it on a scale of 10 million people, it turns out to look pretty beautiful. Okay, I am a little bit of a data junkie. It's beautiful because you start to see patterns emerging. And there's syndromes. It's kind of like the first, you know, shaman or medicine man who said, "Huh, isn't that interesting? His fever went up, his fever came down, and then it went up again. I'm an expert." Right? And that was the beginning of medicine, right? When someone said, "I can describe a syndrome. I don't know what it is. I don't know what caused it. I don't know how to treat it. I don't know what's going to happen. But I can describe the pattern. And there is a distinct pattern. That art of description is at the heart of medicine. It's at the heart of science. And that's the first thing that we did when we started looking at this syndrome data, or syndromic surveillance, as it came to be called, to be able to describe and recognize patterns. There was a pattern for flu. You couldn't miss it. It would smack you in the face, right? Because here we're going along with a sinusoidal curve in terms of respiratory calls, and then something would happen, and it would go 3- or 4-fold increase in that pattern over what was expected. But here's the funny thing. If you're a doctor in an emergency room, you totally miss it until literally there's people in stretchers in the hallway. So at a city level, monitoring 59 emergency rooms, the pattern's stupidly obvious. But at an individual physician on an individual shift, it's very hard to see, certainly not early in the day. So that was kind of my first exposure to this idea that you could take data that is now electronic because we have some sort of transactional system, and the data is being collected for some totally other purpose, right? Dispatch an ambulance. But if you could reuse it, repurpose it, and look for patterns within it, it might be useful. The next thing we wanted to do, though, was not just say that we see this pattern, but when you're in the early days of something happening, to be able to predict. Oh, I've seen this pattern before. I think we're going to see, over the coming weeks and days, some really bad stuff happening, so you should staff up your emergency room. Prediction. And prediction's beautiful. Prediction's beautiful because you can be wrong. There's a lot in medicine where, you can be an expert. In science, you can be an expert. But you don't really know who's an expert until you can know if they're wrong. So let us make a prediction. It's like Schrodinger's cat, right? You exist in a probability. You don't know if it's alive or dead until you open the box. I heard, I was talking to someone who ran the analytics for the Obama campaign in 2012. And she said, when model validation day, election day came, that's what they called it. It was model validation day. Because at some point you made a prediction, and that condenses down, that probability cloud condenses down to a 0 or a 1, right? Truth, falsehood, right? That is what we need. That's what science is. You make a prediction. It's great having a 13-year-old kid because you learn all sorts of stuff you never learned the first time around. So I just learned that Uranus was discovered, speaking of Harlan's astronomy, the location of Neptune was deduced based on the slight wobble in the orbit of Saturn. And so based on that slight wobble, they said, there must be another planet. Before they had instruments to be able to see it, they said, there must be another planet who would be in this place. And then when they finally got the right instrument, they were able to look in that space, and there it was, right? That's prediction. And that's what we need to be able to improve on our use of data. So it's not just description. It's saying, you're going to get sicker. The doctor says you're going to die. That was the power of medicine. And to this day, I remember rounding with physicians, and I was, cocky resident, a good training program. And I was like, I know more about the medications, I know more about the most recent diagnoses, I know more about it than, the old guy who's our attending, who's supposedly in charge. But here's the thing the attending always knew. The attending always knew sick, not sick. I mean, everyone's sick, they're in the hospital. But the attending had that ability to predict who's gonna crash. And we would do the rounds and everything, they seemed to be doddering along, not really paying much attention, and then we would come out of a room and he'd turn to us, the residents, and he would say, "You should check back on Mr. Jones a few times today." And sure enough, Mr. Jones would go down the tubes. And it was that ability to predict what's going to happen that set those early medicine men apart from everybody else, right? This person's going to get sicker, you'll be fine. 90% of what we do in medicine still is, and what I do to my kids, right, is you'll be fine, right? Like that's most of what medicine is. Like you figure out, like, I don't know what it is, but you'll be fine. They hate that. In New York, we started getting pretty good at prediction. So we would say, okay, we're going to monitor sales of pharmacy, over-the-counter pharmacy stuff. So anytime the thing went beep across the scanner, we would get counts of, I would, not like Nirav is suggesting in Syracuse, where you actually know who it was. That's pretty freaky. But we would get aggregate counts. From this store, we sold X number of units of allergy medications or cough medications or zinc or whatever we thought might be useful. And what we saw was there would be this incredible spike in the spring and in the fall in sales of allergy medications. And I actually eventually got data from around the country and looking at the difference in patterns between tree pollen and grass pollen in Texas is really great. It's just really interesting. You start to describe those patterns. But here's the other thing you'd be able to do. You start to be able to say, 2 weeks later, we're going to see a huge amount of school absenteeism and emergency room visits for pediatric asthma. Like clockwork. It got to the point where we started putting out press releases from the health department saying, get your kid on their preventive medication inhaler, whatever, the steroid, because there's a huge spike coming. Now that's a pretty crude prediction. It's a city-level prediction, right? What I'd love to be able to do today is to say, your kid has one of the 13 flavors of asthma out of the 59 flavors that will respond to this, so not everybody, should get their kid on the steroid inhaler. But at the time what we had was the sales of this thing go up, the emergency room pediatric asthma visits, in those 4 weeks, we would some years see 40% of all pediatric asthma admissions. So prediction is the next step. But the prediction isn't enough either. And I have Nirav talked about the hubris of big data, right? The Google flu trends everyone loves. What does everyone love? Everyone loves initially to pump up and hype the new thing that's not really that new. And then when it fails to meet those unrealistic expectations, what does everyone love to do? Crap on it. Right? That's who we are, right? We hype unnecessarily and then we're like, what? You're not perfect? I crap on you. I've been through that hype cycle. And when you're being puffed up, it feels great. You're like, I'm awesome. I didn't realize I was so awesome. I'm on the front page of the Wall Street Journal for this, and then people are like, what? You suck compared to Google flu trends. I'm like, what? Google flu trends? So wait till I get to crap on you. So that's the hype cycle people talk about. And Google flu trends, honestly, they got more hype than they deserved, right? But they're not so bad as what people are saying now either, right? It's just, here is the problem with Google flu trends. From a public health agency, you couldn't drill down, right? So I would say, like, okay, great, there's been more searches. What more can you tell me, right? If I had an increase in emergency room visits that's a potential cluster, I can go and I can investigate. I could say, okay, emergency room, you had 15 people in an unusual age distribution in this area that had this. Let's pull those 15 charts, police powers of the public health department. There may be an outbreak here. Who knows? It might be anthrax. With Google flu trends, you can't do anything. You can't investigate. You can't diagnose. So that's the next stage in our evolution of science, right? You go from description to prediction to diagnosis, where you get to be able to understand exactly what the underlying etiology is. Not just A happens, then B happens, but actually understand causation underlying it. And it's very hard to do that with a lot of data that's at 3 arms lengths. And that's one of the problems that we described with Google Flu Trends and why the improvement didn't happen. One of the things we did was we said, let's put a feedback loop in. So when there's an increase in GI illness in this part of the city, let's put a decision support alert that pops up in their EHR. We did this when like 5% of docs had EHRs. We found a group that was willing to do it. And to tell them, like, collect the specimen and then we're going to test it. And that was pretty cool. So getting from description to prediction to diagnosis. But then this is where I think, in that hype cycle when people are going to be criticizing big data, right? Because everyone's like, big data! I crap on you. Right? What they're going to crap on big data for is it's not actionable. Right? So I know, so what? Tell me something I can use. Right? Tell me something I can use. How do we make it actionable? How do we go from diagnosis to prescription, right? Because it's great to be able to say, doctor says you're going to die. It's better to say, here, take this, you're not going to die, right? And to be able to get to that prescription. For us in New York, again, with this movement, really, to say, let's use found data in multiple ways from multiple streams and analyze it and find clusters, find patterns, predict, right? For me, the shining moment of that was actually when we used it. We put in place the Smoke-Free Air Act, which was an intervention. It's a pretty big policy intervention in New York City. People thought we were crazy. And then we monitored, among other things, right? The one question was, like, is this really going to help people quit smoking? We raised cigarette tax. We were saying, like, is this really going to help people quit smoking? And we monitored by neighborhood, by socioeconomic status within the neighborhood, the increase in nicotine replacement and cessation aids. That was a huge spike when it happened. That was pretty gratifying, to be able to then move from that to evaluating the effectiveness of your intervention. Is this going to work? Right? We do stuff. All the time we do stuff to patients. All the time we do stuff to populations. All the time we do stuff to ourselves. And what we fail to get is insight into whether it worked or it didn't work. And at best we capture it in these vague accumulation of experience, that patina of wisdom, right? Which is good. It's not data. So that was, to me, the learnings from that experience. Let me give you a few other lessons I took from those 10 years. One was, it really helps to have a hypothesis. And this is one of the things that it makes me wonder, like, do I really not understand big data? Because in our experience, we kept getting more, like after 9/11, right? You could go to anyone and say, give me your data. We want to protect you against anthrax, and you've got the data, right? So we got more and more data, but we didn't get better. In fact, we found more and more clusters, maybe outbreaks, and more false positives. And if you kind of think about it, in a certain way, it kind of makes sense. There's a fixed amount of true outbreaks. The more data you get, and frankly, the better your analytics get at finding clusters, the more crazy coincidences you're going to find. Like unbelievable coincidences. And our brains are what? Storytellers. Humans are amazing storytellers. We can take some coincidence and boom, we will make a story that'll knock your socks off. Right? And that's the risk, is as we get more and more data, this is what concerns me, frankly, about the NSA stuff. You can get more data, you're just going to find more pieces of hay in that haystack, that have that same crazy pattern as that, needle did. And let's go find all those clumps of hay and then do fourth order connections between all of them. And then you start scooping in more and more innocent people into this stuff. And your predictive value positive, PVP, starts to go down the more data you get, unless there's one cure for this disease. What's the cure? You have to have a hypothesis. Don't just look for anything. Say, I'm asking a question. This is the question I'm asking. So one of the things that I think is sometimes lacking in the conversation on big data is, do we just do unfocused, tell me anything interesting or not interesting, right? Non-obvious correlations or whatever, but not enough work up front doing what I spent most of my time when I ran the data shop for New York City's health department was 90% probably of the value I added was not in analyzing data. It was in sitting there and saying back to the person, what's the question? Uh-huh. What's the question? I see. What exactly is the question, right? That process of clarifying, what is it that you're trying to get out of this? What is the policy that you're going to change? And spending more of your time doing that before you start interrogating the data, right? Before, because that'll tell you anything you want. And I gotta tell you, there are some crazy coincidences you find when you have a lot of data and you have really powerful tools, right? That you're like, there is no way that, the person who died of inhalational anthrax had a subway card in her house that was distant from where she lived, but it was in the subway station, and the FBI arrested people in Texas who had that same subway stop. And you're like, oh my God, I can totally see it. Right? There's this plot, and her boyfriend, they're making anthrax in Queens. And it's bullshit, you made it up. Right? Because we're really good at doing that, telling those stories, unless we have kind of a rigorous approach to it. The other thing I found was we got incredible value when we polished the stone of what we already had more and more and more and more. So we had that, I told you about that stupid emergency room visit data, right? And we'd had it for like 10 years, maybe 7 years. And we were doing the same stuff to it until we kind of turned our thinking skew and we said, what if we, instead of trying to find clusters, what if we try to visualize the data? To take all those 50 million data points across the country and put it on a one page in terms of a heat map that has the y-axis being the age of the people. And then all of a sudden, those visualizations gave us incredible understanding and insight into what was happening. So it was the same data, it wasn't more data. And I find a lot, people who are dissatisfied with their abilities, and they're like, oh, I just need more data. My data sucks, I need more data. And I'm not convinced that they've polished the stone they already have, and wouldn't be better served sitting down for a second and polishing that a little bit longer before they start gathering more rocks from all over. Now, this is one where, again, I'm a little insecure. I don't think I understand big data. Because in the classic, what people say about big data is the cure for, bad data is more bad data, just get more. And I'm not being funny. I think there's actually something to that. I just don't really understand it. So maybe there's some way, I was talking to the CEO of Palantir. They do the pattern recognition stuff for the NSA. And he said, yes, for you at your scale, I understand why when you were getting your data for New York City with 10 million people, that you would find that. But we're just talking about a whole different scale, and it's discontinuous. Things just change when you're talking about, terabytes of data. Maybe. I don't know. Later on, you'll tell me. Petabytes, thank you. Petabytes. I don't even know what that is. Sounds mildly obscene. The final thing is privacy. And one of the things I learned there was it really freaks people out when you're tapping into data that's already been collected. And maybe we're past all that. I don't know. I don't think so. I don't think so. But when data that's collected for one purpose gets used for another purpose, particularly when it then gets combined with other data sources, and then the concept that you've really de-identified it becomes more and more incredulous because of these mosaic effects, that you can piece together these things, it starts to get creepy. And one of the things that I always found useful was, if I'm doing something and I feel a little bit like, gee, I wish that our friends in the media wouldn't, find out or talk about or publicize this, I shouldn't be doing it. And I think that's been a good moral compass for me. So when we did this electronic health record meaningful use program, there were some people who said, we're paying for it, they got to give us their data. And I was like, I do not want any patient-level data coming to the federal government. I just don't want it. And they were like, but think of all the things we could do, things we can't even tell you what they are. I don't want it. Tell me what it is that you're trying to answer, and we'll see if we can get aggregated data to answer that question. I think we gotta, I don't know. This is the other thing that I think is something in healthcare in particular we have to grapple with as we see about all the possibilities of big data, collecting all of it, line level, matching it, linking it, right, in one big place, one great hackable database. You gotta wonder about that, particularly in healthcare. Maybe we're past all that. Maybe in a Facebook world, none of that matters. I don't know. I call me old-fashioned. So that was kind of my experience on the million to 100 million people level. The next thing was, okay, how about healthcare, which is more done in enterprises, and the size isn't like millions of people. It's like 1,000 people in an office, 1,000 patients for an office, or 10,000 for a clinic, or 100,000 maybe for a hospital. But at that scale, why can't we apply all that we've learned down to this? And I know that there's a lot of criticism of how slow healthcare is to adopt new technologies. And one of the things, the way I think about it now, is in order for any new technology to be taken up into healthcare, three things have to align. In addition to the technology being available, you need three other things. One is, and probably most important, you need payment that supports the use of that technology. It's got to make sense from a financial point of view. Now, there's lots of technologies that just add costs, revenue. They take off great, right? Oh, sure, that technology, that's great. More revenue, revenue, right? That's fantastic. It will get taken up, right? But if the payment model doesn't really support, we're rolling out EHRs to these doc offices, and we were like, this is fantastic. You can make a list of patients, you can call them, you can counsel them, you could be reminded. And they're like, does it slow me down? Because I get paid by the minute, right? For how quickly I can get the patient in and out, right? Are you slowing me down? Don't slow me down, right? Because I don't get paid for outcomes. I don't get paid if the person's not smoking. I don't get paid if the person's healthy. There's no, DRG code for healthy patient, right? I don't get paid for that. Adiagnositis. We need one of those, right? That's a disease. It's like demand destruction. Have any of you heard that term? That's when hospitals worry about admissions going down. That's demand destruction, because people are healthier. It's a terrible ill that we need to cure. Apologies to any hospital executives. I love you. Payment. The second is protections. And I'm not going to be flip about this. Healthcare is just different. We're not going to, the example, Harlan, is Harlan still here? Hi, Harlan. So the example Harlan gave about the iPhone. And, using an EHR should be as easy as using an iPhone and should need no training whatsoever. Maybe, except if I screw up on the iPhone, nothing bad happens. If I screw up on the EHR, patient dies. So do I really, like, is it more like an iPhone or is it more like a car, right? Cars have come a long way, right? But we still make kids, sit in class, do training, be observed, right? It's not like we don't be like, here's a car, it's really usable, go! Right? There's protections that we have. Sorry, Harold. There's protections that we have.
Thanks for asking photos here.
I wouldn't have done it if you weren't here. There's protections that we have, and there's reasons we have protections in healthcare. Around safety for patients, having the patient's best interest at heart, and around privacy. And when I see my really enthusiastic tech friends who are like, why doesn't healthcare just do this engineering optimal solution, right? Just Google index everyone's health records and put it in one really secure place. Not going to happen, right? And the third is processes, and I don't think we talk enough about, and this is kind of the technical assistance piece, I think, that Nirav was talking about. In order for healthcare to really take something up effectively, you need payment that supports it. You need to address, de-risk that technology for healthcare's perspective. And you also need to work on incorporating it into the workflows of healthcare. And that's really hard. And it's actually harder the bigger the institution is. With all respect to what Geisinger has done, amazing things, it ain't nimble. And trying to change a workflow in any hospital, like we implemented 200 doctors in a hospital's outpatient department, and they were still discussing in committee what the order sets should look like on the inpatient side, right? Getting those process changes in healthcare is really, really slow, and the bigger the institution, the slower it is. So to me, it's not such a surprise that things move slowly in healthcare. But the title of my talk was Helping Clinicians Improve Outcomes. And I do see hope for what I think is big data. Maybe it's not. You'll tell me if it is. Maybe it isn't, right? What I think, data, use of data. Let's just forget about the big part. Let's just using data in healthcare, right? I see opportunities in that, where payment has changed. Where payment has changed. And I think there's opportunities where payment is still how many widgets you produce, regardless of quality, safety, or outcomes. I think maybe there's some opportunities to make more profit by reducing your unit cost or length of stay there. Maybe. But that's not what I'm interested in. That doesn't do it for me. So what I am interested in are new payment models that actually provide financial incentives for doctors to keep people healthy and out of the hospital, AKA demand destruction, right? And it's amazing. The largest payer in the country, Medicare, has now said, hey, docs, primary care docs, you get together. You get 5,000 patients, 10,000 patients on Medicare. We expect actuarially for them to cost X next year. If they cost less than X, we'll split the difference with you, as long as quality and patient experience go up. This is amazing. This is amazing. What an opportunity for healthcare to suddenly ask the question, well, how am I going to do that? Huh? Wait a minute. I get paid more if the patient doesn't have an emergency room visit? Hang on, let me change my answering machine message. If you can't wait till tomorrow, call 911. No, I want to change that. Right, that's what's happening now. Literally, these doctors are like, oh, now I gotta, be available if the patient needs help on the weekend, not just tell them to go to the emergency room. Boing. So these physician-led accountable care organizations I'm working with at Brookings, I'm working with 17 of them on 4 improvement projects. I just want to take each in turn. How much time do we have? Can I just talk until you tell me to stop? 15 minutes, okay. And I think there's a lot we can learn in each of these 4 domains from applications of what I think is big data in the rest of the world. One is, okay, I want to reduce emergency room visits and hospitalizations. Well, who do I work on, right? I can't dedicate all those resources to everybody. It would be too expensive. So what's the first generation of this? Where's Jeff? Jeff Brenner? right? So I heard Jeff speak, and I was like, oh my God, he is so much better than I am. He was like, it's stupid, right? We say, like, here's a risk score from 0 to 100, your propensity to, right? That's stupid, right? There's not one dimension of risk, like whether you're going to go to the emergency room or not. There are different groups there's different diagnoses, right? We go from description to diagnosis, right? We're trying to do prediction here. Who's going to go to the hospital in the next year, right? We're trying to do a prediction, right? And Jeff said, there are people who have a lot of ER visits and no admissions. There are people who have a lot of admissions and a lot of ER visits, right? They're different people. There's probably not one cancer. There's 300 kinds of cancer of, just breast cancer. There's probably 300 kinds of ER utilizers. We need to be able to segment them and then have the right intervention for the right segment. One group needs housing. Housing, that's what they need. They don't need more medical care. They don't need a nurse calling them on the phone. They don't have a phone. They need housing, right? We were in San Diego, Beacon Community. They saved $8 million on 32 patients. $8 million they saved on 32 patients. And I was like, one of them needed this lady who they'd had 100 ambulance dispatches going to her house, not a single transport. And no one had stopped to say, what happens when you go to her house? And they said, usually we make her a sandwich. Right, so they got her Meals on Wheels. It's a lot cheaper than scrambling, a rig. So the first thing we've got to do is we need to predict and understand risk for the ACOs. And I really liked what the value of data, right? There is value there now. You can help me understand who I need to focus my efforts and what efforts to focus on for whom and reduce that hospitalization. That's $10,000 per hospitalization that's saved, per unnecessary, harmful. 1 out of 3 of those Medicare patients who get hospitalized then get a complication, right? Like my mom, like probably your mom's, statistically speaking. I hope it wasn't, but oftentimes it is. All right, 2, we talked about volume, velocity, and variety of data, right? That's a big data thing. The variety part is really important in this context because I need to understand not just what happens in my office with the patient, but did they fill the prescription at the pharmacy? Did they show up in someone else's emergency room? Did they, what's going on with the patient outside the 99.999% of the time that they're not in my office? Where are they pinballing around? Most primary care doctors today, no clue. You walk out of the office, see ya, bye, come back. Right? No idea what happens to the patient once they leave. Hopefully, they'll see him again. And then you say to them, have there been any, and this is best practice. This is best practice. Best practice is, when you see them again, ask them about any intervening clinical events. I.e., did you get hospitalized and I didn't know about it? Right? That's the good doc. The good doc should be, you get a page that your patient's in the emergency room and you care. Right? I'm sick and tired of all this talk about empathy, as if the only empathy that we can show is when we're face-to-face with a patient and we're really caring and kind and listening. I don't want to denigrate that. That's really important. But if I don't care to know when you're in the emergency room, I don't care about you. Right? That's not empathy. If I don't use all the data I have to take the best care of you and reduce your chance of having a stroke, I don't really care about you, in my view. So I think doctors are starting to care more in that respect. The third is patient outreach. So it turns out that a bug in the accountable care Medicare shared savings program is that patients are not forced to see you. They can go wherever they want. They don't like the care you're giving, they go somewhere else. And the ACOs I work with hate it. They're like, how can I manage the care of the patient if I can't force them to see me or the doctors that I force them to see? I'm like, I don't know, it's amazing that Zappos sells any shoes. because there's no requirement that people buy shoes from Zappos. It's amazing. They have to work on loyalty. It's crazy. Right? We're like, oh, they're not coming in for their wellness visit. I'm like, really? What'd you do? I'm like, send them a letter? I'm like, yeah. Really? Send them a letter. Have you tried anything else? Have you done an A/B trial? Anyone here in healthcare? Has anyone ever done an A/B trial of how to get your patients to show up? Anyone? You have. You really, in healthcare, done an A/B trial on patient outreach. I really want to talk to you. We have a lot to learn, right? But like the Obama people, when they're like, when that thing said, hey, and I was like, really? Hey? Obama said hey to me? Really? I double-click lunch? I was like, well, I'm going to open that one, right? They know you're going to open that one. Of course they know, because they tested it, right? Why don't we in healthcare send them an email that says like, hey, lunch? They'd open that email. They would. You know they would, right? Except it's like, oh, it's a form letter from the hospital. I don't like even thinking about that, right? Yeah. Right, whatever. So that's the other thing that, I was talking to someone who is in, they do real tech, not health tech. And they're like, yeah, we assemble the database, we virtualize the databases, and we have all the pieces everywhere, and then we assemble it live when the person needs it. I'm like, really? That seems really slow and inefficient. He said, oh no, because when the person starts to log into the system, we predict who they are and what they're going to want to see. And we start to prefetch the database before they even ask the question. And I was like, oh man. Like, what if when a patient called the doctor, it like recognized the caller ID and went into the chart, figured out when they had last been seen and what the medication was, and prefetched for me just the information I need. Why don't we have that in healthcare? Like, that just makes me so sad. That our docs are doing the epic training and clicking through the, no, not on any vendor, clicking through screen after screen after screen after screen after screen to try to find the information they need. Like, why can't we apply some of that intelligence here in healthcare? So those are the kinds of things that we're going to need to do in medicine. And I just want to comment on this protocols. So one of the things that these ACOs really need to figure out is how to more consistently deliver what the evidence-based care is. And I got to tell you, I work with a lot of community docs. They're not too keen on the guidelines. And they kind of feel like it doesn't add that much. And some of say, yeah, and see, the future is this personalized, everyone's, I'm personalized. They're like, I'm personalized medicine. I sit with every patient. They're a person. I'm a person. It's personalized. I'm like, that's not personalized medicine, right? That's like chaos. That's no evidence. That's not evidence-based. That's not like finding the right evidence base for just this person, right? Like the stuff that Harlan's going to do, which is amazing, which is what we have to go. Like, we're not going there yet. Like, first we got to, like, everyone who needs the flu shot should get the flu shot. Like, the people you didn't give the flu shot to, you didn't make a personal decision not to give them the flu shot, goddammit. You just didn't give it, right? You just didn't do it. You didn't make a decision not to do it. And what I would say is, make it easy for the right thing to just happen, right? The evidence-based thing should just happen. Person needs a flu shot, they should just get a flu shot, right? There should be an order for a statin, a dumbed-down base statin for every person with diabetes, in my view. And the doc can change it, right? That, to me, is what a base protocol might be. And I know it horrifies people who are like, no, we need to have like the right thing. But I'm like, 90% of the care out there is nothing. It's chaos. It's no evidence. Let's at least get the basics down. And then if we vary, let's study that variation and say like, oh, interesting, when people varied from that guideline, They did these things, and they had these outcomes for these patients, and let's learn from it. But unstudied variation is not learning. It's, in my view, chaos. Okay, so that's it on helping clinicians improve outcomes using big data. Can I just say one more thing? Okay. Where it's at is not going to be, big data is not going to be most impactful in helping clinicians improve outcomes. It's going to be in helping patients improve their outcomes. Because all of those limits that I said about payment and protection and privacy and the processes, right? I don't have any of that, but I do have this. I don't have any of that, right? My incentive is like, I don't want my mom to die. Like, that's my incentive. I don't have a financial incentive. I don't think I need one, right? My workflow process is like, I get a notification. That's my workflow, right? I turn on, there's a notification that shows up there. That's a pretty good workflow, right? And it's just that much easier for this consumer technology stuff to go out there and empower the patient and help them choose a plan, choose a doctor, find the right treatment, find a clinical trial for themselves, find other people like themselves, donate their data to science. Like all of that great stuff that we can come out of there, in my view, we should strive and just make it just climb, mountain climbing up that, but the patients are just going to take a chairlift to the top on the consumer tech, and that's where the action's going to be. Thank you very much.